Welcome to this deep dive. Today, we're really zeroing in on something crucial: how you can effectively use AI software for prostate cancer diagnosis with MRI. Staying ahead of this tech curve is, well, vital for patient care.
Absolutely. And we're grounding our discussion today in a presentation by Professor Anwar Patani, a real leader in this field. Consultant radiologist, professor of cancer imaging, involved with ICS, the PAARS committee. His insights are invaluable.
Exactly. His talk, Prostate AI Software Using It Effectively, is our guide. So our mission here is pretty straightforward. Figure out the key things you need to look for when picking AI software, compare some tools out there, and give you practical tips for actually using it in your clinic.
Let's dive in. First up, slide 2, Professor Patani's disclosures. Important context.
Transparency first.
He noted research support and advisory roles with Siemens Healthineers and Lucida Medical, and he holds stock in Lucida Medical. These kinds of collaborations are common, but it's essential you know about them.
Good point. Okay, slide 3 laid out the learning points, which really align with what we want to cover for you today.
Yep, 3 main things. Criteria for selecting this DLA-CAD software that's deep learning algorithm computer-aided detection. Second, a look at the tools actually available commercially.
And third, practical advice. How do you actually make this work in practice?
Exactly. That's the goal.
Okay, slide 4 jumps right into the guidelines. EAU 2024 pathway. MRI is central now, isn't it?
It absolutely is. Central for men at elevated risk. It has 2 main jobs, according to Professor Patani. Risk stratification, helping you decide who needs a biopsy, and then guiding that biopsy if it is needed. And AI tools. They're aiming to boost both of those functions for you.
Makes sense. And slide 5 really hammered home the benefits of this MRI pathway, referencing the vision meta-analysis, level 1A evidence, which is significant.
It is. Big benefits highlighted. Fewer unnecessary biopsies for your patients, less diagnosis of that indolent low-risk disease.
The kind you might just watch anyway.
Precisely. And importantly, better detection of the clinically significant cancers, the Gleason grade group 2 or higher ones you really need to find. Plus, more accurate targeting with the biopsy.
And he introduced those key concepts: rule out and rule in, NPV and PTV, crucial metrics for evaluating any tool, AI included.
Fundamental concepts for you when deciding if a tool, AI or otherwise, is actually helping diagnostic confidence.
So slide 6 gave some hard numbers from Vision, focusing on biopsy-naive men. What stood out there?
Well, pretty striking numbers. Compared to just doing systematic biopsies up front, the MRI approach meant almost a third, 32% of men avoided biopsy completely.
Wow, that's a big reduction in procedures.
Huge. And for those needing biopsy, 29% more positive cores found, 12% less detection of the insignificant GG1 disease, and crucially, 9% more detection of the significant GG2 plus cancers.
So really strong level 1A support for MRI triage first.
Undeniably.
Okay, so if MRI is that good, where does it fall short? Slide 7 looked at PIRD's 2.1 performance, right, based on that ortho meta-analysis.
Yes, a large analysis over 13,000 patients. It looked at detecting those significant GG2 plus cancers using the PIRDS 3 to 5 cutoff.
And the takeaway?
Sensitivity is actually very good, typically over 90%.
Yeah.
So you're generally finding the important cancers. But the specificity is only moderate, often under 60%, and it's highly variable between readers and centers.
So that's the issue. Lots of false positives, especially with PIRDS 3 lesions, leading to biopsies you didn't necessarily need to do.
Exactly. That variability and lower specificity is the key challenge.
Yeah.
And that's the opening where AI could potentially offer real value, helping you reduce those unnecessary biopsies.
Right. Which brings us to the PICAI challenge on slide 8. This directly compared AI to radiologists.
It did. A big head-to-head comparison.
Yeah.
Top 5 AI algorithms versus 62 radiologists. Importantly, this was standalone AI performance, the AI reading on its own, not assisting a human.
Okay, and what did they find?
Pretty compelling results published in Lancet Oncology. On average, the AI performed better than the radiologists using PIRDS 2.1. Similar sensitivity, but critically, 50% fewer false positives.
50% fewer. That's substantial for reducing unnecessary workups.
Absolutely. Also, 20% fewer insignificant GG1 cancers picked up and 50% fewer false negatives at that PIRDS 3 to 5 threshold really highlights the potential if it can be integrated effectively.
Which leads to the big question on slide 9. Is this stuff ready for your routine clinical use?
Well, the performance data, like from PICAI, is promising, especially for finding those GG2 plus cancers. But Professor Patani added some important caveats for you.
Such as?
AI assistance doesn't seem to help everyone equally. Highly experienced leaders might not see the same benefit. And getting the workflow right is critical.
And we don't have a ton of real-world studies yet, even though tools are getting CE marked and FDA cleared.
Exactly. Lots of tools appearing. You can check resources like the AI for Radiology Grand Challenge website, but prospective real-world validation is still lagging a bit. That's a key thing for you to consider.
Okay, so conceptually, how should you think about using these tools? Slide 10.
The idea is to see DLA-CAD as a diagnostic assistant, something to help radiologists, maybe especially those with less experience, improve performance, consistency, and aid in biopsy management and planning.
Got it. And slide 11 broke down the typical functions into two main roles for you.
Right. The assistant role helping you with efficiency, accuracy, consistency. Things like highlighting, measuring, suggesting scores.
Making the reading process smoother, potentially more standardized.
Exactly. And the second role, biopsy management, providing segmentations or coordinates that directly feed into your biopsy decisions or fusion systems.
Streamlining that part of the workflow. Okay, so slide 12 brought in more practical stuff, further considerations based on Sonnekraut's work.
Yeah, moving beyond just performance. You need to think about selection criteria, what clinical tools are essential, the user interface, workflow integration, and crucially, SOP's standard operating procedures.
Let's break those down. Slide 13 focused on selection criteria. Necessary, recommended, aspirational. What's absolutely necessary for you?
Non-negotiables. External validation against radiologists or pathology. You need proof it works. And regulatory clearance, CE mark, FDA approval. Basic safety and efficacy checks.
Makes sense. What about recommended criteria?
Performance should be similar to standard of care radiologists you'd compare yourself to. Training data needs to be diverse, multi-site, multi-vendor to ensure it's robust.
So it doesn't just work on the data it was trained on.
Right, and it needs to integrate easily into your workflow without slowing things down.
Yeah.
Generalizability across different MRI vendors and field strengths, 1.5T and 3T, is also key for practical use.
And the nice-to-haves, the aspirational criteria.
Things like validation and prospective trials, being deployable on multiple platforms, handling both biparametric and multiparametric MRI, and maybe even incorporating clinical data like PSA and age for a more complete picture.
Okay, that's helpful. Then slides 14 and 15 dug into the clinical tools the software should offer. Again, necessary, recommended, aspirational. What must it do for you?
Absolutely necessary. Detect, localize accurately with contours or heat maps, and classify suspicious lesions. And critically, provide some kind of probability or suspicion score for clinically significant cancer for those lesions. That's the core function you need.
What's recommended on top of that?
Interaction. You need to be able to accept, reject, or tweak the AI's findings. It shouldn't be a black box. Also, prostate volume calculation is vital for PSA density, a key metric for you.
Especially after TURP or other procedures.
Yeah.
Good point. And aspirational tools.
Things like heat maps for lower suspicion areas, auto-generated PAARS reports to save you time, user-adjustable ROIs, maybe some explainable AI features so you understand why it flagged something.
Lesion expansion tools for biopsy or RT planning, exporting for fusion systems.
Yes, those DICOM-RT object exports are really valuable for integration, and maybe even letting you adjust the false positive threshold, depending on the clinical situation. Lots of potential enhancements there. Okay, slide 16 showed an example of typical AI output on a workstation. What were the key elements visible?
Right. So in that example, you typically see a segmentation of the whole prostate gland, maybe the different zones marked out too.
The anatomy outlined.
Yeah. Then a suspicious lesion is contoured, highlighted somehow, and you'll usually see quantitative data displayed right there, things like ADC values from the diffusion sequences, lesion volume,
The numbers.
and crucially, there's that likelihood score or a suggested PI radius category, a link to that specific lesion.
Okay. And while that contouring is helpful for seeing the lesion, you pointed out something interesting that was not explicitly shown in that specific example regarding intervention.
That's a key observation. That particular example didn't seem to show a specific target region with, say, coordinates for guiding biopsy cores or planning focal therapies.
So it highlights the suspicion, but doesn't necessarily pinpoint the exact spot to target for treatment or biopsy in that specific view.
It suggests that while many AI tools are good at finding and characterizing, the direct guidance for intervention might still be an area needing refinement or might be presented differently in other tools or modules.
Gotcha. Then slide 17 showed some example AI reports, one from Lucida Medical, Prostate Intelligence, and one from Quivim, QP Prostate. What's the main purpose of generating these kinds of reports?
The primary goal there is really standardization, standardizing how the AI findings are communicated to the rest of the clinical team.
So everyone gets the same info in a clear format.
Exactly. These reports typically summarize the key bits. The lesions the AI detected, where they are in the prostate, their size, their volume, and that AI-derived risk score or suggested PAARS category. And often, this is presented right alongside relevant patient data, like PSA density, giving a concise, integrated overview for the referring clinician or the MDT meeting.
Okay, let's shift gears slightly. How do we actually interact with these AI tools? Slides 18 and 19 got into the radiologist AI interface using FDA terminology. CADE, CAS. What do these mean for us in practice?
Yeah, this FDA classification, McNamara and colleagues laid it out. It helps us understand the intended function of the AI device. It's quite useful.
So CADE.
CADE stands for computer-aided detection. These tools primarily flag suspicious areas. They draw your attention to potential abnormalities you might need to look closer at.
Just detection, pointing things out.
Right. CATS, on the other hand, is computer-aided diagnosis or characterization. These go a step further. They provide an assessment of what has been detected, often giving a probability score for malignancy or suggesting a PAARS category.
So CADE finds it, CADX gives an opinion on it.
Pretty much, yeah. And CADX obviously combines both detection and characterization.
Okay. What about CAT?
KCAT is for computer-aided triage. These tools help prioritize which cases should be read first, maybe based on an AI assessment of high risk or urgency.
Useful for workload management.
Potentially, yes. Theta would be for autonomous interpretation, where the AI makes the diagnosis on its own.
Which isn't standard practice for primary diagnosis in prostate MRI yet.
No, definitely not. And then non-CAD just refers to other AI tasks like segmentation for planning or maybe helping generate the report text, but not direct detection or diagnosis.
And how the device is classified really impacts how it fits into the workflow, right?
Absolutely. Whether it's just highlighting or suggesting a score or prioritizing cases dictates how you interact with it.
Okay. And slide 20 gave some industry examples based on these types. Lucida was listed as CADEX, Siemens AI as CADEX, and Deep Health Quantib as CADE. What does that tell us about interacting with those specific tools?
Well, based on that categorization, it suggests the Lucida system aims for a more comprehensive level of assistance, helping with detection, giving a risk score, characterization, and maybe even helping prioritize cases, triage, plus auto reports.
Okay, multifunctional.
Siemens AI, as CADEX, also offers detection and characterization, suggesting scores, and includes features like letting the user edit the lesion contours and exporting data for biopsy planning.
Right.
Whereas Deep Health and Quantib, categorized as CADE, detection only, primarily provide those heat maps we saw. They highlight suspicious areas.
But leave the segmentation, the classification, assigning PAARS, and the biopsy planning more squarely in the hands of the radiologist or urologist.
Exactly. More manual interpretation based on the AI's guidance map.
And slide 21 briefly mentioned deployment options, integrating into PACS, vendor platforms, standalone workstations. Seems like there's flexibility there now.
Yeah, there's definitely a trend towards more interoperability. Many vendors offer plugins for major PACS systems like Sectra or work through vendor-neutral archives like Blackford.
So you can use it within your familiar environment.
Right. Or sometimes the AI is embedded directly in the MRI vendor software like Siemens Singo.via, or it might be a completely separate standalone workstation. Some offer multiple options.
Good to know. Slide 22 then showed that CADE system again, the Quantib Deep Health example with the heat map.
All right, illustrating that concept, you see the likelihood of cancer heat map overlaid, visually guiding you to high probability zones.
But no automatic contours or scores provided by the AI itself in that mode. The radiologist does the delineation and classification.
Correct. Full control, using the map as a guide.
And that contrasts sharply with the CADEX system shown on slide 23, the Siemens AI RAD companion example. Much more automation there.
Yes, exactly. That system automatically detects and delineates the suspicious lesions. It calculates volume, ADC values, gives a level of suspicion score, even suggests a PAARS category.
A much more complete initial analysis.
Right. Now, the radiologist still reviews all that. They can edit findings, accept or reject them.
Still in control, ultimately.
Still in control, but the AI does more of the upfront work. And it facilitates exporting that lesion info directly for biopsy planning systems.
Okay, which leads us perfectly into the really critical part.
Sure.
Integrating AI into clinical workflows. Slides 24 and 25 focused on the AI for decision support workflow. How does that one work?
So in this model, the AI analysis runs either concurrently while you're reading or perhaps just before you open the case.
Yeah.
The AI's predictions, the risk scores, the highlighted areas, the segmentations are then available to you as you interpret the images yourself.
So you see both side by side or integrate the AI info as you go.
Exactly. You incorporate the AI's input along with all the other clinical information and your own assessment into your final report and biopsy decisions. It acts as an adjunct, an assistant.
And the potential benefit is?
Potentially particularly helpful for less experienced readers, maybe improving consistency. But, and this is crucial, the AI output needs to be clear and actionable. And we must be aware of automation bias.
Automation bias, the tendency to just trust the machine.
Exactly. Over-relying on the AI suggestion without critical appraisal, that's a real risk.
And slides 26 and 27 gave a pretty sobering case example of that potential pitfall, didn't they? The 74-year-old patient.
Oh, absolutely.
Yeah.
A stark reminder. Here you had a case where both the radiologist called it PAARS 5 high suspicion, and the Siemens AI gave a concordant high suspicion score for a lesion in the transition zone.
So human and AI agreed. Likely cancer.
Looked like it, but extensive biopsy sampling ultimately revealed only chronic inflammation, no cancer.
Wow. So even with concordance, false positives happen.
Absolutely. It highlights that even when human and AI agree, you can still be wrong. You always need to consider the full clinical picture and maintain that critical oversight. Don't blindly follow the score.
Wise words. Okay, what about the next workflow model? AI as an additional reader, or the safety net workflow from slide 28. How's that different?
In this setup, the process is sequential. First, you, the radiologist, perform your interpretation completely independently. Read the case as normal, make your calls. Then separately, the AI analyzes the same images. Usually it's run at a very high sensitivity setting.
High sensitivity, so
Yeah.
it's designed to catch potentially everything.
That's the idea. Aiming to identify any subtle lesions or suspicious areas that the human reader might possibly have overlooked. It acts like a second pair of eyes, a safety net.
Okay, flagging potential misses for you to review afterward.
Exactly.
But the trade-off, as hinted on slide 29 with that heat map example, is that high sensitivity usually means
More false positives. That's the inevitable trade-off. Because the AI is tuned to be super sensitive to avoid missing anything, it's going to flag a lot more areas that turn out not to be clinically significant cancer.
right. So the MDT and the urology team need to be really careful about evaluating those extra AI flags.
Critically important. They need to rigorously assess those AI-only findings and avoid just jumping to biopsy based purely on the AI flag. Otherwise, you risk what you might call urologist automation bias.
The biopsying things just because the computer flagged them.
Pretty much. Need careful clinical correlation.
Slides 30 and 31 then showed data from a study by Gwenzel et al. Using quantum deep health in this additional reader mode. What did that find about catching missed cancers?
Well, it did show some potential benefit for detection. The AI identified clinically significant GG2 plus cancers in about 4% of cases that were potentially missed on the initial human read.
Okay, so it did find some potentially missed significant cancers.
Yes. And it also detected additional significant lesions, maybe second lesions, in about 8% of cases. So there's definitely a signal that it could improve overall sensitivity.
What was the downside? What was the impact on workload and false positives?
Yeah, that's where the trade-off becomes really clear. The cost of that increased sensitivity was a hefty 54% increase in the total number of target lesions identified.
Wow, over 50% more things to look at and discuss.
Exactly. A substantial increase in review work for the radiologists and the MDT. And the false positive rate per case essentially doubled.
Doubled. Ouch.
Yeah, and slide 31 showed the impact on performance metrics. The per-lesion positive predictive value, the PPV, dropped significantly from 46% down to 30%.
So lower chance that any individual flag lesion is actually cancer.
Right, and the specificity also declined. It clearly demonstrates that inherent tension. You crank up sensitivity, you typically lose specificity, and generate more false alarms.
A tricky balance. Okay, then slide 32 described a third option, the AI-assisted targeted review workflow. This sounds like it tries to blend elements of the others.
Exactly. It's kind of a hybrid approach. In this model, you start with a high-sensitivity AI pre-screening the MRI studies. It highlights the potentially suspicious lesions.
Okay, AI finds the potential targets first.
Right. Then the radiologist focuses their detailed review and subsequent biopsy planning primarily on these AI-flagged areas. The idea is the radiologist needs to apply high specificity in their judgment when assessing these flags.
So AI does the sensitive sweep, human does the specific confirmation.
That's the concept. But critically, the radiologist also needs to verify the cases the AI called negative. You can't just ignore the clear scans. You need to make sure the AI didn't miss something significant.
Ah, okay. So review the positives carefully, but also check the negatives.
Exactly. It's not just focusing on the flags.
And the goals here are enhanced detection, maybe improve workload efficiency by focusing attention.
Potentially, yes. Leverage the AI sensitivity, focus your expertise. But again, that risk of automation bias is always lurking. You have to critically evaluate the AI's suggestions, both positive and negative.
I can't afford to blindly trust it either way.
Never. Diligent review is key.
Slide 33 then gave that nice summary overview of these different AI-integrated reading workflows for single-reader settings. We had decision support.
Yep. AI assistant concurrently.
Additional reader.
The safety net second read.
Assisted target review.
The hybrid pre-screen model. And it also mentions some other potential future applications like AI purely for triage or maybe high confidence filtering, perhaps automatically handling the clearly negative or clearly positive cases.
Interesting ideas, and potentially, way down the line, standalone AI, though we're not there yet for primary diagnosis.
Not yet. The slide referenced an upcoming publication in European Radiology that will apparently delve into these workflows in more detail, which will be worth looking out for.
Good to know. And slide 34 had that visual workflow diagram showing where AI slots in alongside the radiologist and the MDT.
Yeah, those diagrams can be quite helpful just to visualize the flow of information and decision points in each different model.
All right, let's get really practical now. Implementation. Slide 35 hammered home the absolute necessity of standard operating procedures, SOPs, when you bring AI into the workflow. Why are these so vital?
SOPs are just fundamental, absolutely critical for ensuring both safety and consistency when you start using AI. It doesn't matter which workflow you choose.
Safety and consistency.
Yes. You need clear, well-defined guidelines so that everyone on the team, all the radiologists, maybe the techs, the urologists involved, uses the AI tool in the same way, understands its role, and crucially, understands its limitations. Professor Patani was very clear. SOPs are essential.
And slide 36 then listed the key elements that should probably be in our local SOP for AI-assisted prostate MRI reading. It looked pretty comprehensive.
It is, and it covers the critical points. It starts with the basics. Always consider the patient's clinical history first. Don't read in a vacuum.
Context matters.
Always. Ensure the image quality is adequate. Garbage in, garbage out applies to AI too.
Check the scan quality.
Yep. Then verify the AI segmentation, especially at tricky spots like the prostate base and apex where errors can happen.
Look closely at the outlines.
Right. Critically review the ROIs and heat maps the AI identifies. Don't just accept them. And be aware of common false detections of things the AI might commonly flag incorrectly.
Like inflammation.
BPH nodules. Exactly. Be mindful of how things like infection, post-biopsy changes, or stromal BPH nodules might fool the AI, and also be aware of its potential blind spots. Maybe it struggles with very small lesions, or lesions in certain difficult locations, like the anterior fibromuscular stroma.
No, it's weakness.
No, it's weaknesses. Then, of course, use all the available MRI sequences in your own interpretation to classify lesions. Don't just rely on the sequence the AI might favor.
Use the full MPMRI dataset.
Always. And assign the final PAARS or Likert score based on your overall assessment, incorporating the AI score as another piece of data, but not solely relying on it.
Integrate, don't just adopt the AI score.
Precisely. Adjust your tolerance for false positives depending on the clinical situation. Maybe you accept more flags in a high-risk patient screening scenario versus a diagnostic workup.
Okay.
Ensure the DICOM or T objects the contours are exported correctly if you're using them for fusion biopsy or radiotherapy planning. Accuracy there is critical. And finally, if the tool offers it, utilize the AI output to help auto-generate parts of the report, but always review and verify the final report for accuracy before signing off.
Makes sense. And the quote there was,
SOP stands for Standard Operating Procedure. Consistency is key. Couldn't agree more.
Okay, we're nearing the finish line. Slide 37 provided an excellent checklist. Key questions we should all be asking vendors and maybe ourselves before buying any DLA-CAD software. Really practical stuff.
Absolutely crucial questions to nail down before you commit.
Yeah.
First, what specific clinical work task are you actually hoping this AI will help with? Be clear on the goal.
Define the problem you're solving.
Exactly. Then, Can the vendor provide solid, validated performance data, not just marketing claims? Ideally, data at both the patient and the individual lesion level.
Yeah.
And how does it compare against experienced radiologists?
Show me the data.
Show me the data. Does the software offer any specific proven utility for those tricky PAARS 3 lesions? That's often a key area of interest. What's the user interface actually like to use? And what workflows does the vendor recommend? Importantly, do those recommended workflows actually fit with how your department currently operates? Or will it require massive changes?
Practicality check.
Big time. Is the software compatible with your images, your MRI scanners, your protocols? Does it need special calibration? How automated is it versus how much user input is needed?
Technical compatibility.
Yep. Are there explainability features? Can you see heat maps, likelihood scores, anything to help understand why it made a call?
Understand the black box a bit.
Try to, yes. And finally, what are the outputs? Does it generate structured PI-RADIS reports? Does it give lesion volumes? And critically, can it export ROIs or segmentations in a format that's compatible with your reporting system, your biopsy fusion system, your radiotherapy planning system?
Interoperability of the outputs, really key.
Vital for actual integration.
Great checklist.
Yeah.
Okay, finally, slide 38 summarized the key learning points about these AI radiologist interaction workflows. What were the main takeaways for you from the whole presentation?
I think the biggest overarching theme is that human-AI collaboration seems to be the most effective path forward right now. It's not about replacement, it's about assistance.
Collaboration, not replacement.
Exactly. AI definitely shows potential to improve detection rates, maybe reduce that troublesome inner reader variability we see, and potentially, hopefully, lead to fewer unnecessary biopsies, especially for those PIRES 3s. It can also contribute to better workflow efficiency, maybe through triage or filtering functions, but we urgently need better ways to measure success. We need robust benchmarking metrics that are specifically designed to evaluate the rule-in and rule-out performance of these integrated AI radiology workflows in the real world, not just standalone AI metrics.
How do the team perform together?
Precisely. And crucially, we just need more high-quality prospective studies that rigorously evaluate these real-world interactions, quantify any actual efficiency gains, and really assess the generalizability. Does it work as well in different hospitals with different patient groups?
More real-world evidence is needed.
Desperately needed. So wrapping up this deep dive, it's clear AI has huge potential in prostate MRI diagnosis for you. It can really assist with detection, interpretation, workflow.
For sure. But as Professor Pahani emphasized, you need to be thoughtful about implementing it. Careful selection based on criteria, ensuring it has the right clinical tools for you, understanding the interface and workflow implications, and having solid SOPs in place.
Absolutely. It's moving fast, so clinicians like you need to stay informed, ask the tough questions, and figure out how to best use this technology to genuinely improve patient care in your practice.
Maybe think about which of these workflows seems like the best fit for your department's needs right now.
A great closing thought. Thanks for joining us on this deep dive.